Good afternoon. Thank you for joining us for the 2020 STD Prevention Conference Symposium 10, Clinical Uncertainties B. I'm Leo Parker, Health Administrator for the Fulton County Board of Health's Sexual Health Prevention Program, and I will serve as co-moderator for today's session. Now I'll turn it over to my colleague, Dr. Laura Bachman, to introduce herself.
Hi, I'm Laura Bachman. I'm the Chief Medical Officer for the Division of STD Prevention and the Clinical Team Lead in the Program Development and Quality Improvement Branch at CDC.
This is a recorded session, and we will encourage everyone to join us for a live Q&A with the presenters on Friday, September 18th from 3:50 to 4:30 p.m. Eastern Standard Time. Our first presentation of today's symposium is Diagnosing Neurosyphilis, Challenges and Future Approaches by Dr. Christina Mara. Dr. Mara completed residency training in neurology and fellowship training in infectious diseases at the University of Washington in Seattle, Washington, USA. She is a professor and vice chair of academic affairs in neurology, and she has an adjunct appointment in medicine, infectious disease at the University of Washington. Dr. Mara's primary research interest is factors that influence the clinical course of syphilis, with a particular focus on HIV and on neurosyphilis. She received the American Sexually Transmitted Disease Association Achievement Award in 2014 for work in this area. She also participates in multi-center clinical research on the neurological consequences of HIV, and she provides general neurological and neuro-ID care in inpatient and outpatient settings. Ladies and gentlemen, Dr. Christina Mara.
Okay, well, thank you for the introduction and for the opportunity to be here. I'm going to talk about tests for neurosyphilis diagnosis and something besides the CSF-VDRL. And I think the thing we have to start with first is asking ourselves, what is neurosyphilis? And this is a nice picture that was taken from a recent New England Journal article. And I just want to point out this right side of the figure, where we talk about after infection, about 40% of people experience CNS invasion. So how is CNS invasion defined? It's defined by identifying the organism in spinal fluid or cerebrospinal fluid or CSF. And there may not be any other abnormality, certainly not a clinical abnormality, and the CSF may be otherwise normal. Some proportion of individuals who experience CNS invasion go on to develop early neurosyphilis, in particular asymptomatic neurosyphilis. So how do we define that? So asymptomatic neurosyphilis is defined purely by CSF findings, so glucose, cell count, protein. Now, some proportion of individuals with asymptomatic neurosyphilis will go on to develop either early or late symptomatic disease. So how do we define that? We define that by clinical abnormalities plus CSF abnormalities. We think of the CSF-VDRL as the gold standard for neurosyphilis diagnosis, but it's really a very flawed gold standard because the sensitivity is low, although the specificity is high. And just to remind you, the sensitivity is the proportion of persons with a positive test among those who have the disease, and that's the sensitivity. And the specificity is the proportion of people who don't have the disease who have a negative test. So how do we know that the CSF-VDRL is a poor gold standard? Well, you can go back to very old literature. These numbers are taken from Merritt, Adams, and Solomon's textbook published on neurosyphilis in 1946. It was based on over 2,000 individuals with neurosyphilis seen at the Boston City hospitals. And they looked at reactive CSF Wassermann test, the predecessor of the CSF-VDRL, and showed that it was positive in anywhere from 72 to 100% of individuals, depending on the form of neurosyphilis they had. So asymptomatic, meningeal, meningovascular, general paresis, or tabes. I'm going to talk to you about alternative neurosyphilis diagnostic tests in CSF. And the three things we'll specifically talk about are identification of T. pallidum in CSF by nucleic acid amplification. We'll talk about the CSF-TPPA titer as an alternative antibody test. And we'll talk about CSF CXCL13. CXCL13 is a B-cell chemokine that has been suggested to be a good diagnostic test for neurosyphilis. Now, the performance of any test depends on your neurosyphilis diagnosis. And if we were just to define neurosyphilis based on the CSF-VDRL, we'd never do any better than our flawed gold standard. So what I chose to do for this talk was to tell you about these 3 tests based on what's published in the literature, but also to go back to my data set from the University of Washington syphilis study and come up with uniform definitions so we could compare between tests. So the UW syphilis study was conducted from 1996 to 2014. The entry criteria were extremely simple. The patient had syphilis and they or their providers thought that they should have a lumbar puncture. Participants who enrolled had a standardized history and exam, a lumbar puncture, and a blood draw. The graph on the left just shows you the number of people who enrolled per year and is trying to point out that in the light orange bars that a fair proportion of our participants enrolled more than once. So we had 1,199 syphilis episodes from people who enrolled in Seattle in 1,009 unique individuals. And because of the demographics of syphilis in Seattle, and also because we are more concerned about neurosyphilis in people living with HIV, 81% of our participants were people living with HIV. So I said I was going to use uniform definitions, and this is what I chose. So people who came into the study were actually classified by syphilis syndromes. So asymptomatic neurosyphilis, I added that they had to have CSF white cells above 10, so no neurologic symptoms and CSF white cells above 10. Ocular syphilis and otic syphilis were defined by symptoms and signs, vision loss and hearing loss. And then symptomatic meningitis, neurologic symptoms, and CSF white cells above 10. So when I talk about all these diagnostic tests, I'm going to use these 4 definitions of neurosyphilis. So beginning with the CSF-VDRL, how did it perform in the UW syphilis study? So here I'm showing you, I'm analyzing 929 episodes, 116 with asymptomatic meningitis, 81 with ocular, 62 with otic, and 54 with symptomatic meningitis. And you can see that while the specificity was high, the sensitivity was very poor, 45 to 49%. The literature says that the sensitivity of the CSF-VDRL is 30 to 70%, so we're sort of within that range. What about these other tests? So beginning with identification of T. pallidum in CSF by nucleic acid amplification. This is a paper published by Marks and colleagues looking at a number of studies that examined the sensitivity and specificity of detection of T. pallidum DNA by PCR in CSF. And the studies all used one of 2 targets for the PCR, but I want to point out to you that the diagnostic criteria were all based on CSF, and they differed within studies. So you can see that study 2 and study 6 used just a reactive CSF-VDRL as the gold standard. 3 and 4 used VDRL with a treponemal test, or VDRL or a treponemal test. And then 1 and 5 used other CSF findings. So not uniform definitions, but all based on CSF. The numbers are shown and they're pretty small. And you can see that the sensitivity ranged from 50 to 100%, and the specificity ranged from 61 to 100%. So we used a very analytically sensitive RT-PCR in our study on CSF, and this PCR is about 10-fold more analytically sensitive than the DNA PCRs. You can see I had 914 episodes, and again, my 4 categories of neurosyphilis diagnosis. And while the specificity of the very sensitive RT-PCR was high, or the specificity was high, the sensitivity was really low. And I think that goes back to this issue of neuroinvasion. Neuroinvasion is defined by identifying the organism in CSF without other CSF or clinical abnormalities. When that's what you have, you're going to see that the sensitivity is going to be low because there's not going to be CSF abnormalities and there's not going to be clinical abnormalities that you pick up with the gold standard. So what about the CSF-TPPA titer? So long ago, Luger and colleagues published a paper suggesting that the TPHA titer with a cutoff of 1 to 640 was both sensitive and specific for a neurosyphilis diagnosis. So we published a paper a few years ago looking at the sensitivity of the CSF-TPPA using that same cutoff, because we figured we already had pretty good specificity with the VDRL. And again, I went back and analyzed using my 4 diagnostic criteria, and you can see that the sensitivity was quite high, was 94 to 96%. The specificity was really low, 6 to 17. And if you had just looked at reactive CSF-TPPA, the sensitivities would be around 80%. So it really did improve that and took you close to what the specificity of the CSF-VDRL was. There was just a paper published looking at a clinical situation in which people were diagnosed with neurosyphilis by clinicians before and after the CSF-TPPA titer was available as a diagnostic test. And the investigators were able to show that the number of individuals who were diagnosed with neurosyphilis, or the proportion that were diagnosed with neurosyphilis after the availability of the CSF-TPPA titer went down by about half, suggesting that use of this test eliminated some of the false positive diagnoses. The numbers are small, but this article came with a nice editorial by Khalil Ghanem at Hopkins suggesting that we really should take on the CSF-TPPA with the titer cutoff of 1 to 640 as a diagnostic test. Okay, and then finally, CSF CXCL13. So as I've said, CXCL13 is a B-cell chemoattractant. It's long been known that CSF CXCL13 levels are high in individuals with neuro-Lyme. And a small study many years ago suggested that it was also elevated in people who had neurosyphilis. So we published a paper now 10 years ago looking at CSF CXCL13 for diagnosis of asymptomatic neurosyphilis. We focused on people living with HIV because that's a population in which this diagnosis can be hard to make. So our gold standard was CSF white cells above 20 when the CSF VDRL was non-reactive. We used 2 cutoffs for the CSF CXCL13 based on the lowest and highest quartiles. So you'll see that with a cutoff of more than 10 or 10 or more, the sensitivity was 97%. With a cutoff of 250 or more, the specificity was 93%. Since that paper was published, there have been 7 subsequent studies looking at CSF CXCL13 for neurosyphilis diagnosis. They don't all agree, but the things that they do agree on are that higher CSF concentrations are seen in symptomatic neurosyphilis compared to asymptomatic neurosyphilis, that the level is probably not affected by HIV, and that the level declines after neurosyphilis treatment. What the studies don't agree upon is the diagnostic cutoff. We need a diagnostic cutoff if we're going to use this test clinically. So I again went back to my data set. I had 379 syphilis episodes. Most of the individuals were people living with HIV. And I made receiver operator characteristic curves for each of my definitions of neurosyphilis. So asymptomatic meningitis, ocular, otic, symptomatic meningitis. And then I used something called Uden's index to determine the best cutoff to maximize sensitivity and specificity. And what I found was that the cutoffs were different depending on the form of neurosyphilis. So for asymptomatic meningitis, a cutoff of 66.6 gave a sensitivity of 79, a specificity of 76, not fabulous. Similarly, ocular syphilis, the cutoff was 85.5. For otic syphilis, it was very similar at 83.5, but you can see that the sensitivity was a little bit higher for otic, but still we're in the mid-70s range. And then for symptomatic meningitis, the cutoff was much higher, 184.2, perhaps consistent with this idea that symptomatic neurosyphilis is associated with a higher CSF CXCL13 concentration. And you can see I had the best sensitivity and specificity for that definition of neurosyphilis with 83% and 81%. Okay, so I've told you a bunch of numbers. Let me go through it just to summarize. So again, in our data set, the CSF-VDRL had high specificity, but low sensitivity, consistent with what's described in the literature. For our very sensitive RT-PCR, very high specificity, equivalent to the CSF-VDRL, but poor sensitivity. And that's recapitulated in the study that used different definitions and used CSF findings for the gold standard for neurosyphilis. For the CSF-TPPA, again, with a cutoff of 1 to 640, you can see the sensitivity is high. It's comparable or even a little bit better than the VDRL. And then for CSF-CXCL13, the sensitivity and specificity, I think, are lower than we would really like to see. But the advantage of this test is it's one that can give us both some reasonable sensitivity and reasonable specificity, which none of these other tests are able to do. But I think we need more work there to come up with cutoffs that we all agree upon and to validate work that's been done. So I think what we're left now with is using the CSF-VDRL to optimize specificity and the CSF-TPPA with this 1 to 640 cutoff, optimizing sensitivity. So what are new approaches? This is a picture of my dog, Obi, swimming in Lake Washington last Saturday, and it was supposed to make you think about what's on the horizon. So one thing we haven't talked about is the fact that even the CSF-VDRL is not available in some places. So for example, in China, the CSF-RPR is widely used. There are point-of-care tests for syphilis diagnosis. We've done a couple of small studies using them on CSF. You have to modify how it's done, but the manufacturers could optimize those tests for CSF pretty easily. And the dual platform test that both gives you a treponemal and a non-treponemal test would be the ideal platform. We're collaborating with investigators at UC San Francisco to look at using RNA-seq to determine host gene profiles that might be able to tell the difference between uncomplicated syphilis and syphilis and neurosyphilis. That's certainly not an approach for resource-limited areas, but it may give us some insight or more insight into the disease than we have now. And I think that the last thing I want to say is that people moan and complain that we diagnose syphilis by antibody tests, and we diagnose neurosyphilis by antibody tests, and that's the best we can do right now. But there are lots of neurologic infections that are defined by antibody tests. For example, West Nile. We can do a PCR, but it's not very sensitive. So we do IgM antibody detection in CSF. So I don't think that we're really so primitive in the neurosyphilis world. So I'm going to end there. I want to thank you for your attention, and my email is here if anyone wants to send me a question.
Our next presentation is entitled Ceftriaxone Allergic Patients with PID. What are the outpatient options? This will be presented by Dr. Kathy Hsu. Dr. Kathy Hsu is the Medical Director for the Division of STD Prevention and HIV/AIDS Surveillance, Massachusetts Department of Health, and the Director of the Rectal STD/HIV Prevention Training Center of New England. She is an Associate Professor of Pediatrics and attending physician in pediatric infectious diseases at Boston University Medical Center. Dr. Hsu graduated from Brown University School of Medicine in 1995, completed a pediatric residency at Columbia, and completed a fellowship in pediatric infectious diseases at the Boston University Medical Center. She also completed a second STD prevention fellowship jointly sponsored by the Association of Teachers in Preventive Medicine and the Centers for Disease Control and Prevention, and received her Master's of Public Health and Epidemiology from the Boston University School of Public Health. Thank you for speaking with us today. I look forward to your comments, Kathy.
Terrific. And thank you so much for that lovely introduction, Laura. As Laura said, today I was actually assigned the topic of ceftriaxone allergic patients with PID. What are the outpatient options that we have for ourselves? And the point at which we're recording this talk today is July 30th, 2020. And I'll just note for the record that the CDC STD treatment guidelines, or the STI guidelines for 2020, have not yet been released. And we all look forward to that. And I'll come back to that at the very end of this presentation. I think without understanding where we are in the context of PID epidemiology, even though I'm going to focus mostly on clinical aspects today, I think if we don't talk a little bit about the fact that PID is actually incredibly uncommon these days. These are data that were initially published in the STD surveillance brochure that the CDC annually publishes now around September of every year for the previous year's data. And in it, in the women's health section, they reviewed two data sources, the National Disease and Therapeutic Index, as well as a paper that was published by Kristen Kreisel and others at CDC. That's the left hand and also the right hand. In both of these data sources, which we use as proxy measures for the incidence of PID, what people have come to realize over time since the 2000s, when nucleic acid amplification testing, certainly for chlamydia and gonorrhea, gradually became more and more widely available, and efforts were made to expand annual screening in young women less than the age of 25, we have made gains in PID incidence, meaning it's actually dropped, which is terrific. I think the question on everyone's mind right now in July of 2020 is whether or not these gains will persist. Will these declines in PID persist through this year under pandemic conditions where routine STI screening has decreased? And it makes us all very nervous, since those of us working on the front lines are clearly seeing a positivity rate in the patients that we are seeing who tend to be more symptomatic. Positivity rates for GC and chlamydia have climbed in many settings, both STD clinic settings that have remained open, as well as clinical settings such as adolescent centers all around the nation. This is an anecdotal report that I'm sharing with you right now, so I think all of us wonder what will happen next. So I've set the stage for saying to you all that it's actually really important to pay attention to PID, even though we've made such wonderful gains and reductions of PID overall. So on to a case, and this is an oldie but goodie. Many of us in the training center network have used this over time to teach from our slide decks. So this is a case of KL, a 17-year-old woman with mild abdominal pain, no other symptoms. Her past medical history is one that includes severe hives to amoxicillin at age 8 and a severe rash to cephalexin at age 12. Her social history is remarkable for no use of tobacco or drugs that she reports, and one sex partner in the last 3 months with whom she reports vaginal, oral, and receptive anal exposures. On exam, this patient had a low-grade fever, some mild hypogastric tenderness with deep palpation. It was really quite subtle, and a purulent discharge from the endocervix. And there was cervical motion tenderness, perhaps not an outright chandelier sign, but certainly mild cervical motion tenderness. There were no other findings that indicated that there could be any other cause to this other than PID. Some additional labs included Amsel's criteria, which was done, examined, and clinically she was deemed not to have BV. Her nucleic acid amplification tests for gonorrhea and chlamydia were pending at the time of care. So let me point out that KL is not actually your usual case for those of you working on the front lines, right? Often the history of allergy is only to penicillin and more vague. Like, my mom told me when I was little I had a rash, or something happened, like I swelled up when I took penicillin. That I just heard yesterday in adolescent center. In those with a history of pen allergy, what we know from data, not anecdote, reported prevalence is about 8 to 10% in the United States, and at less than 2.5% report cross-reactivity with cephalosporins. The risk is highest with first-generation cephalosporins and cephalosporins that have similar R-group side chains to specific penicillins. By the way, none of the ones that we typically use for PID treatment, cefoxitin, cefixime, and ceftriaxone, do any of these cephalosporins have those similar R group side chains? The answer is no. And a practical pearl that many of us use on the front lines is sometimes those who report a penicillin allergy have either a documented, like in the electronic medical record, or perhaps can recall treatment with a cephalosporin without adverse events. And clinicians then go ahead and use a cephalosporin treatment. It kind of gets you off the hook for worrying about our patient KL today, who not only reports hives to amoxicillin, but also a severe rash to cephalexin. So under ordinary non-pandemic circumstances, we would have all been in a room together, and I would have asked you the following question. How many of you would admit this patient for a parenteral antibiotic regimen? Or perhaps to go for the gusto anyway, despite this rash allergy, a severe rash allergy, you wouldn't hesitate and you would still treat with ceftriaxone combined with doxycycline and 14 days plus minus metronidazole. Or azithromycin. Would you have combined that at a higher dose level for 1 to 2 doses, followed by 250 POQ day times 12 to 14 days, plus minus metronidazole? Or would you have been left with the last regimen on this list, levofloxacin 500 milligrams POQ day, metronidazole times 14 days? Well, those of you in the know who have been working with the CDC STI guidelines for the last 5 years would recognize all of these as potential options under listed alternatives within the CDC STD treatment guidelines. Let's take a closer look at what's actually recommended for cephalosporin-allergic patients. Your options may be sparse, but they do still include 2 sort of standard options. One set is parenteral, one set is IM and oral. The parenteral regimens include clindamycin loaded together with gentamicin, followed by maintenance dosing of gentamicin, or that regimen that I just mentioned on the previous slide, some azithromycin, followed by a lower dose of azithromycin plus minus metronidazole. But all of these would have headed you in the direction of hospitalizing this young teenager, and you might have wanted to avoid them. If you wanted to avoid it, your options are sparse indeed. Certainly it would be important to rule out pregnancy, and then a consideration for the use of a quinolone can be operationalized. And that would be levofloxacin, or ofloxacin, or moxifloxacin, dosed at different intervals, combined with metronidazole, a tried but true regimen that was certainly working for us all back in the day when there was relatively little quinolone resistance amongst the gonococci that we were treating. Now, in 2020, this continues to be a problem, although we recognize it more as a problem within smaller sexual networks of men who have sex with men. Quinolone resistance is still a concern, maybe an increasing concern in your heterosexual patients as well. And it would be important to get a GC culture before you start. And if it turns positive, treatment should be based on results of antimicrobial susceptibility testing. And I'll just remind everybody in the audience today that all of these regimens have more than a shred of evidence that they do in fact work to ameliorate longer-term outcomes that we care about with PID. That's why they're listed as potential alternative regimens. You don't have to make it up, unless and until you run into a situation where these are not available to you, or you wind up having a gonococcal culture that maybe is indicating resistance to a quinolone. Then you're gonna have to get really creative with an infectious disease physician in your backyard who can hopefully advise you, or perhaps an allergy consult as well. And the question on everybody's mind in July is, what will the 2020 CDC STI guidelines say? And of course, all of us are looking forward to the release, and none of us really know exactly when they'll come out. Hopefully the MMWRQ will slow down at some point. So this patient was in fact treated with levofloxacin and metronidazole, and follow-up at 72 hours, a crucial element, demonstrated complete resolution of her signs and symptoms. She responded. Nucleic acid amplification tests actually indicated that the cause of her mild PID was probably Chlamydia trachomatis, and her GC culture was negative. Success. Before I leave this topic, let me wax on about two additional thoughts on PID in general. The first is that there has been progress in the STD literature in terms of a randomized controlled trial that has finally been published that was led by Harold Weisenfeld and colleagues that examined the question of ceftriaxone and doxy with or without metronidazole, the perplexing problem of when we do and when we don't add metronidazole. And the answer in this particular trial that enrolled over 200 women, most of whom were over the age of 20, was that probably longer term outcomes at around 30 days were improved by the addition of metronidazole, thus helping us in our thinking that the pathophysiology has all along been a bacterial infection such as Neisseria gonorrhea or Chlamydia trachomatis, dragging along perhaps neighborhood anaerobes that would infect the endometrium, result in PID, and we'd always had this question, could we improve on both bacteriologic outcomes and longer term outcomes? And in this study, it's fair to summarize by saying there were significant differences between the two groups, although not huge. And what was also remarkable in these women is that many of them tolerated the regimens for the purposes of treating PID, which included both doxycycline and metronidazole, which some of you have struggled with on the front lines, oral tolerance with this. Sometimes you have to nurse your patients through the process. Nonetheless, in this trial, the adverse events didn't appear to be that different with or without metronidazole. And these data will be part of the component driving changes in upcoming 2020 STI guidelines. That sort of moves us into 2020. That trial was actually published earlier this year in February. I'm now going to go backwards to an incredibly old study from 1993. I guess we should call that incredibly old. I don't really think it's that incredibly old, I guess. But I think it makes a beautiful point. Hillis et al. Published in the American Journal of Obstetrics and Gynecology that patients with subsequent impaired fertility, you could actually differentiate them on the basis of those who were treated within 2 days of onset of abdominal pain versus 3 or more days. And using that as a simple cut point throughout, it was astonishing that the outcomes were quite different. If you were treated earlier, there were less odds of you having subsequent impaired fertility. Quite dramatic differences, even on the order of days. Early treatment influences fertility. So to summarize, although PID incidence may have been decreasing prior to the pandemic, concerns have been raised for a return in PID cases due to declines in routine screening. Outpatient and inpatient treatment alternatives exist. They may be sparse, but they do exist. For Cephalosporin-Allergic patients, close follow-up is helpful in general, but especially when treating with alternative regimens. And close follow-up has always been helpful, especially in the younger patients who you are not even certain have gone off and picked up the completed regimens, the oral regimens that you need them to pick up from the pharmacy. It's really important to check in with people to see if they are actually better at 72 hours. Otherwise, they merit hospitalization for parenteral therapy. More evidence indicates better anaerobic coverage for PID leads to better outcomes in a recently published randomized controlled trial. And PID, I would say in 2020, is still a bacteriological emergency, and outcomes are better if treated more swiftly. We know this to be the case with meningitis, with pneumonia. It is no different for pelvic inflammatory disease. Swifter treatment leads to better outcomes. I'll stop there, and thanks so much for your attention today.
Thank you, Dr. Hsu, for that presentation. Next, we will have a presentation titled Optimal Duration of Antibiotic Therapy for Symptomatic and Asymptomatic Rectal Chlamydia Infections by Dr. Stephen Jordan. Stephen J. Jordan, MD, PhD, is an assistant professor of medicine in the Division of Infectious Diseases at Indiana University. He received a Doctor of Medicine degree and Doctor of Philosophy in Cell Biology degree from the University of Alabama at Birmingham. He then completed his internal medicine residency and infectious disease fellowship training at the University of Alabama at Birmingham. As a physician scientist with expertise in the management of sexually transmitted infections, especially chlamydia, Stephen treats patients with STIs at the Marion County Bellflower Sexual Health Clinic and has an active chlamydia translational research program. Stephen is on the editorial board of Sexually Transmitted Diseases and has served as an expert advisor on pelvic inflammatory diseases for the CDC. Ladies and gentlemen, Dr. Stephen J. Jordan.
Thank you so much for that introduction, and thank you to the conference organizers for inviting me to give this talk. I have no disclosures, and I'd like to start with a case that I think will help frame our discussion today. So let's say you see a 33-year-old male who comes into the STD clinic complaining of 3 days of rectal pain. So 3 weeks ago, he had unprotected receptive anal sex with a new male partner. The symptoms that he complains of are rectal discharge, pain with defecation, and urges to defecate. He denies dysuria, abdominal pain, urethral discharge, diarrhea, and fevers. On exam, he has a non-bloody rectal discharge that's noted, and the rest of the exam is limited due to pain. So he's tested for HIV and syphilis. Those tests are negative, and you diagnose him with proctitis. So in addition to empiric treatment for gonorrhea and HSV, you prescribe doxycycline to cover rectal chlamydia, but you wonder about the duration. And specifically, you wonder, could this be LGV needing a longer treatment, or is it just a severe non-LGV rectal chlamydia infection? So that kind of frames our discussion today. As you know, chlamydia is caused by Chlamydia trachomatis. This is a bacteria that infects mucous membrane surfaces of the eye, the pharynx, the urogenital, and anorectal tracts. Chlamydia rates are increasing. We're all familiar with this graph in the bottom right-hand side of the screen, and reinfections are common. So we're going to see moving forward plenty of rectal chlamydia infections and need to know how to treat them. Rectal chlamydia infections occur by direct inoculation, by receptive anal sex, as in men who have sex with men, transgender women, and some women, and also likely by cross-contamination from vaginal secretions because the proximity from the vagina to the anus is so small. Reported rectal chlamydia prevalence rates are, the medians are in men who have sex with men, 9%. In men who have sex with women, there's very limited data, so I put the range up there, 0 to 12%. We did a study published just last year in men who denied ever engaging in receptive anal sex, and the rate was 2%, and that was in about 80 men. And then in women, about 9%. So it is very common. So in approaching rectal chlamydia, it's important to understand the different serovars and the diseases that they're associated with. So the ocular serovars A through C are associated with trachoma, which causes blindness in developing countries. When talking about rectal chlamydia, though, we really need to distinguish between the genital serovars D through K and the LGV serovars L1 to L3. So the genital serovars are associated with the non-ulcerative anogenital chlamydia infection. In women, this manifests as vaginal discharge, cervicitis. In men, discharge and non-gonococcal urethritis. And then rectal infections may present as proctitis, which is pain in the rectum. Now, LGV, or lymphogranuloma venereum, is a very invasive ulcerative disease that manifests with pain and massive lymphadenopathy and causes anogenital LGV. Rectal infection causes proctitis and procticulitis, and urogenital infection the organism can drain to the regional lymph nodes and lead to massive lymphadenopathy, which are termed buboes, and you can get what's termed the groove sign because the femoral and inguinal lymph nodes on either side of the inguinal ligament enlarge, and you get this groove that's being formed. So very, very invasive and destructive. So rectal LGV is a worldwide epidemic. In 2003, a cluster of rectal LGV infections was reported in men who have sex with men in the Netherlands, and then it was reported worldwide. Currently, the LGV prevalence is less than 1% in men who have sex with men. It's very rare in men who have sex with women and women. The best data we have from the US suggests that it's prevalent in 1% of MSM, but it can be as high as 60% of detected rectal chlamydia infections in one study. There's a number of risk factors that have been associated with the presence of rectal LGV, being MSM or a transgender female, high-risk behaviors such as group sex or chemsex, fisting, inserting anal toys, etc., being HIV positive or infected with hepatitis C, or having a partner that has HIV, a history of syphilis, and then older age. So these are things to think about when you're trying to assess the risk for rectal LGV infection. So what are the clinical manifestations of rectal chlamydia? So most non-LGV chlamydia is asymptomatic, about 75%, and most LGV infections are symptomatic, about 75%. When present, when symptoms are present though, typically rectal chlamydia presents as proctitis or inflammation of the rectum, or proctocolitis, inflammation of the rectum and the colon. And so the spectrum of signs and symptoms, rectal chlamydia varies significantly from asymptomatic to just very mild rectal pain or irritation, all the way up to full-blown lymphadenopathy, fistulas, and very destructive disease that in some cases of LGV can be misdiagnosed as inflammatory bowel disease like Crohn's or ulcerative colitis. It's important to appreciate that the more severe the infection, the more invasive and destructive it appears, the higher the likelihood that the infection is caused by LGV. So confirming LGV is difficult though. There are several limitations that need to be recognized. One is that the chlamydia gnat detects both LGV and non-LGV serovars, but it doesn't distinguish them. So if you want to distinguish LGV, you need to send an LGV specific test, but those are uncommon, not everyone can send one, and they're also relatively slow. The turnaround time may be a week or longer. And the LGV clinical manifestations vary widely. They can be asymptomatic or mild disease, and frequently they can overlap with non-LGV serovars. I wanted to highlight this study that looked at the sensitivity and specificity of 7 different anorectal signs and symptoms at predicting LGV infection. And you can appreciate that none of these signs or symptoms are very sensitive. So the highest one, discharge, had a sensitivity of 51%, but many of them were very specific. So the 2 highest, bloody discharge, tenesmus, the feeling that you need to have a bowel movement, were very specific at 99%. So frequently these symptoms aren't present, but when they are, they should raise suspicion that this may be LGV that you're dealing with. So regarding the optimal antibiotic choice, it's likely doxycycline. The 2020 STD treatment guidelines aren't available yet to know what's recommended for sure. But increasingly, observational studies highlight that doxycycline appears to be superior to azithromycin. An important caveat worth mentioning is that this has not yet been confirmed in a randomized controlled trial, which is the gold standard for demonstrating superiority of one antibiotic or one treatment over another, but several are in progress. I do want to highlight that Julie Dombrowski from the University of Washington is going to be presenting some of the first results from their randomized controlled trial at this conference. So I'm looking forward to that data. I wanted to highlight this meta-analysis, which included 8 studies comparing both the pooled efficacy for azithromycin was 83%, for doxycycline it was 100%, so a 20% difference in efficacy is pretty significant. But importantly, the overall quality of the studies that were included in the meta-analysis was poor, again highlighting that to really confirm that doxycycline is superior, we need a randomized controlled trial. So the optimal treatment duration is less clear. Historically, we've treated non-LGV rectal chlamydia for 7 days, and then invasive disease like rectal LGV for 21 days. LGV treatment, importantly, is almost always empiric because confirmatory testing is not available at the time that treatment needs to be provided. So the clinical uncertainty that arises is when should empiric prolonged treatment be provided for LGV in asymptomatic or symptomatic cases? And so I think the key to answering that question is assessing risk in your patients for rectal LGV. So suspicion for rectal LGV should be based on risk factors for rectal LGV and then symptoms and exam findings that suggest LGV. So if we were to plot LGV risk factors versus rectal signs or symptoms, If your patient had both of those, they had a large number of LGV risk factors and then a large number of signs or symptoms that may suggest invasive disease, then I think you would empirically treat them with 21 days of doxycycline, and that absolutely is I think indicated. And then on the opposite end, if they didn't have either of those, then likely you would treat them for non-LGV chlamydia, because it doesn't seem likely that LGV that there are risks for LGV. But what about these two other scenarios where you have someone who is at risk for LGV but doesn't have many symptoms or is asymptomatic, and then someone who has a whole lot of symptoms and severe disease but doesn't seem to be at risk for LGV? Should they be treated with 21 days or should they be treated with 7 days? So I want to highlight two studies that I think will be helpful in answering those questions. The first is a retrospective study that used short course, or that evaluated short course doxycycline for confirmed LGV. So this was a study of 60 men that had confirmed LGV. They all received less than 21 days of doxycycline. 83% of these men received 7 days, 17% received 14 days, and half of them were asymptomatic. Almost half admitted to rectal symptoms, and 12% of these men had proctitis. The median time to a test of cure visit in these men was 31 days. And the study findings were an efficacy with short course doxycycline of 97%. So one male failed, and it's likely that he was actually reinfected. So the take home from this study, it's retrospective. Of course, there are definite limitations, but I think the take home message is that shorter courses of doxycycline may be sufficient for LGV, especially asymptomatic or mildly symptomatic LGV. What about the other scenario where you have someone who has significant rectal signs or symptoms but doesn't have a lot of LGV risk factors? Well, this study looked at 21 days of doxycycline for proctitis and then stratified subjects by LGV status. So it was a study that included 46 subjects. They all received 21 days of doxy, and then the subjects returned post-doxycycline for 4 different time points, weeks 1, 2, 3, and 6. And the data is shown here on the left in the graph. The y-axis is percent positive. The black bars are the LGV proctitis group, and the white bars are the non-LGV proctitis group. And you can see that the LGV proctitis group, after 21 days, they all cured. And in fact, 90% of them had cured by day 14. And what's remarkable, I think, is the non-LGV proctitis group, they all cleared by day 7. This is even more remarkable when you consider that nucleic acid tests tend to kind of lag clinical or true cure as you would measure with culture, because of just detection of residual nucleic acids in collected specimens. And so I think it's the take home from this study is that LGV proctitis, we get 100% cure in 21 days. And compared to non-LGV, which has 100% cure in 7 days, LGV proctitis really does need a longer duration. And definitely 21 days is likely more than sufficient for curing proctitis due to LGV. So I want to present one possible way to implement these data in a treatment approach to rectal chlamydia infection. One would be first just evaluate symptoms. Are symptoms present, yes or no? If no rectal symptoms are present, then treat for non-LGV with 7 days of doxycycline. The data suggests that even if LGV is there, a short course is likely highly efficacious. If symptoms are present, then evaluate risk factors for LGV. If those are present, then treat for LGV with 21 days of doxycycline. Reflex the to LGV testing if a chlamydia test is positive, and then consider a test to cure at 4 to 6 weeks. If you have someone that's symptomatic but doesn't have risk factors for LGV, then evaluate for severe symptoms that may suggest LGV. Is there a bloody discharge, tenesmus? If there is, then you likely should go ahead and treat for LGV with 21 days of doxycycline. Alternatively, you can consider using a shorter course like 7 days of doxy with interval LGV testing, and then reevaluate on day 7. And if symptoms persist or LGV testing was positive, then extend treatment out to 21 days. So just circling back to our case, so our individual did have risk factors for LGV. He was MSM, he had rectal discharge, he had severe symptoms, and so he was given a diagnosis of severe proctitis likely due to LGV. He was given empiric LGV treatment with doxycycline for 3 weeks, and a chlamydia gnat from a rectal swab was positive, and a subsequent LGV test was also positive, confirming LGV rectal infection. 1 week later, his symptoms had resolved, and his most recent partner was asymptomatic and was given 7 days of doxycycline. So thank you so much for your attention. I look forward to the live Q&A session. My email address is listed there, so please contact me with any questions.
Thank you, Dr. Jordan, for that nice presentation. The final talk today is entitled Treating Pregnant Women with Syphilis When Penicillin is Unavailable. Are there alternate options? And this will be presented by Dr. Jean Sheffield. Dr. Jean Sheffield is the director of the Maternal Fetal Medicine Division and a professor in the Johns Hopkins Medicine Department of Gynecology and Obstetrics. Her areas of clinical and research expertise include medical and surgical complications of pregnancy with a focus on infectious diseases and immunizations in pregnancy. Dr. Sheffield received her undergraduate degree from the University of Notre Dame and earned her medical degree from the University of Alabama at Birmingham. She did her residency in OBGYN there at UAB and then completed a maternal fetal medicine fellowship at the University of Texas Southwestern Medical Center in Dallas, Texas. She's board certified in both obstetrics and gynecology, as well as maternal fetal medicine. Dr. Sheffield serves on a number of national boards and committees, is currently on the board of directors for the Society of Maternal Fetal Medicine, and serves as the chair of the MFM division of the American Board of Obstetrics and Gynecology. She works with the National Institutes of Health and the CDC, helping the clinical guideline development process, focusing on infectious diseases and vaccination in pregnancy.
Thank you for the wonderful introduction. I'm going to spend the next 10 to 15 minutes talking to y'all about treating a pregnant woman with syphilis when penicillin is unavailable, and are there alternative options? And this is, I thought 15 minutes won't have anywhere near enough time, but we're so limited on the number of our options that I'm hoping to take 15 minutes to do this talk. So we'll kind of move on. The only way to prevent congenital syphilis is to prevent or at least treat maternal syphilis. So we've got to deal with how are we going to find that woman that is pregnant, that has syphilis, and make sure she is adequately treated. So I know I'm preaching to the choir here. You guys have noticed that syphilis rates in the country are certainly on the rise. These are the cases kind of between 1941 and 2018. And syphilis, even as far back as, 100 years ago, has always been a significant issue with the public health population. So as you can see here, this is congenital syphilis rates, and congenital syphilis rates have a tendency to mirror primary and secondary syphilis rates among reproductive age women. So you can see since 2013 or so, we're starting to see a significant rise, and unfortunately the 2019 numbers and have also continued to rise. So what are our treatment options? Right now, the CDC for 2015, the treatment guidelines say that penicillin G is the only known effective antimicrobial for preventing maternal transmission to the fetus and treating fetal infection. And, that has been in place since probably the, 1940s or so when penicillin was first discovered. Penicillin has been the drug for the treatment of syphilis, particularly in pregnancy. So I'm a history buff, and I love to read the history of syphilis and syphilis treatment. I've got a whole ton of monographs sitting in my office. It's one of people's favorite gifts to me is to find these great old monographs. And I pulled out this one. This is from 1880s. And it started going through what was available for the treatment of syphilis at the time, the non-penicillin treatment options. So, debridement of the lesions. They used to mash them. They used to surgically debride them. They would starve the patient. They thought that because there was what looked like fatty infiltrates of the secondary syphilis lesions, they thought if they starved the patient, they could decrease the lesions and eventually treat syphilis. When mercury came out, it was considered the most efficacious agent, par excellence, highest repute. That was supposed to be the drug that was going to cure syphilis. Arsenic was utilized in the 1910s, considered the poison of kings, but also the savior of syphilis. They thought that was the next big thing, and then bismuth in 1924. Silver nitrate used to be used to treat the primary and secondary syphilis lesions, and they would use it on congenital syphilis lesions. They would also make sure people were abstaining from tobacco and rum because they thought that might worsen syphilis lesions. So a whole lot of different things. Obviously, we look at those now and go, oh my gosh, they're barbaric. But at the time, that was what was available. And then in the 1940s, John Mahoney, working in the venereal disease research lab, first reported the use of penicillin for the treatment of syphilis. There were a few reports earlier than that in laboratory animals, but he was one of the first ones to report actually the use in humans. And interestingly, even in 2020, we still have no significant measurable resistance to penicillin. So after he came out in the 1940s, we saw this huge drop in syphilis rates. I put the graph down here. You can see this was 1940 and between 1940 and 1945. We just saw this huge bottoming out of syphilis rates. They also, however, in the 20 years after penicillin was found to be highly efficacious in the treatment of syphilis, they did attempt a number of other broad spectrum antibiotics, and across the board got suboptimal results. So what they had available at the time never seemed to work quite as well as penicillin, and that is still true today. We know that syphilis therapy is incredibly efficacious. This was a study by Jim Alexander and our group back at Parkland. This was now 21 years ago, but these were patients that were treated with bicillin appropriately, and you can see the treatment rates or the treatment efficacy rates range anywhere between 95 and 100%. And though I didn't put this data in there, we took a look at what we considered treatment failures, and it turns out almost all of those were reinfection, or they were patients that continued to be positive because they didn't reach, the time frame from treatment to delivery. We know that if you do adequate treatment, CDC recommended treatment guidance with benzathine penicillin, you see significant drops in titers. Secondary and primary syphilis do have a tendency to drop a little bit faster than early latent and late latent or unknown duration. But you can see it does take some time from the time you adequately treat somebody until their titers actually go down to what we consider adequately treated. We also know from data both by Lisa Ollier and Martha Rack, again, back at UT Southwestern at Parkland, we know that once you have evidence of, say, congenital syphilis and you adequately treat a mother during the pregnancy, the resulting time period after treatment, you see a decline in, or see a decrease and eventual resolution of evidence on ultrasound and evidence of abnormalities such as anemia, thrombocytopenia, and liver function abnormalities in the infant prior to birth. So we know that treating a pregnant woman will cross the placenta, treat the baby, and result in improved evidence of congenital syphilis. But again, that was in using appropriate bicillin regimens recommended by the Centers for Disease Control. So obviously over the years, we've had intermittent concerns about penicillin shortages, both here in the United States and around the world. The World Health Organization, back in December of 2017, reported some data they had collected after receiving a number of anecdotal reports in 2015 of benzathine penicillin G shortages. And they collected data between 2014 and 2016 from a number of different countries. And you can see about 41% of the countries that reported results reported a benzathine penicillin shortage at some point during that time frame. So it's a significant issue, and you'll notice it's not just developing nations. It's occurring everywhere. And some of the reasons for these benzathine penicillin G shortages include the supply chain and financial issues for the various countries. So the World Health Organization, when they put out their syphilis screening and treatment for pregnant women recommendations, they do try to address this. So for the recommendations for the early treatment of syphilis, so that is primary, secondary, and early latent syphilis of no more than 2 years duration. They use 2 years versus a number of other places that use 1 year. They, of course, recommend, benzathine penicillin G is the optimal choice. However, they do have a section down here under recommendation 6 that says if it cannot be used either due to penicillin allergy or it's just not available due to stockouts, the World Health Organization STI guidelines suggest, this is for early syphilis, remember, using erythromycin orally or ceftriaxone 1 gram IM daily for 10 to 14 days, or azithromycin, just a one-time dose. And they do have their caveats down here, although erythromycin and azithromycin do treat a pregnant woman. We know the pregnant woman is treated. Unfortunately, they don't completely cross the placental barrier. And so we don't think that the fetus is adequately treated. So if you use one of these regimens, the erythro, the ceftriaxone, the azithromycin, they do recommend treating the infant then after delivery. They mentioned that ceftriaxone is an expensive option and it is injectable. It's not able to be used in a number of different locations. Doxycycline we don't use in pregnancy, and we'll talk a little bit about that. For late latent syphilis, the World Health Organization again recommends benzathine penicillin, but has a caveat: if it's not available, they do just recommend using erythromycin orally for 30 days, 4 times a day. So not an easy regimen for our pregnant women to use. One, because erythromycin is not usually tolerated very well in pregnancy because of the nausea vomiting issues, but also because you are requiring a woman literally to take a tablet 4 times a day for 30 days. So not optimal, but is available for those patients where benzathine penicillin is not available. There was a nice paper that came out of Sexual and Reproductive Health Matters this past year. It looked at 62 different guidelines representing about 128 countries, and they compared them to the World Health Organization guidelines. And what they found was about 68% of the guidelines did allow for alternative non-penicillin-based therapies. Some of them were following the WHO guidance, which was the erythro, the ceftriaxone, azithro, amoxicillin. Some of the regimens were a probenecid regimen on top of other combinations. A couple mentioned doxycycline or minocycline, which we don't usually use in pregnancy. One of them mentioned acetylspiromycin. And most of the non-penicillin guidance was from the Western Pacific, Africa, and Southeast Asia. About 50% did have a nice section on penicillin desensitization, and only about 12 of the guidance actually truly addressed the global penicillin shortages and what can be done for that outside of just the alternative non-penicillin therapies. So let me just in a couple of slides address a couple of the different medications we're using outside of penicillin. Ceftriaxone has been one of the ones that's made it to the top of the list. It crosses the placenta well. There is one case series with 11 women that had early syphilis, either primary or secondary. They were less than 20 weeks gestation. They were all treated with ceftriaxone, and there were no treatment failures. However, this is just one case series. There's another one from 2017 looking at amoxicillin and probenecid, plus or minus ceftriaxone. Patients had an appropriate response, but again, that was just 2 cases. There is no study right now that has been published that has directly compared ceftriaxone to benzathine penicillin G. So right now, benzathine penicillin G is still the main medication recommended Ceftriaxone is an option if benzene penicillin is not available. Cefixime has also kind of moving its way up, though there is no data in the non-pregnant population. There is a World Health Organization sponsored trial currently evaluating the efficacy of Cefixime for treatment in early syphilis patients, but these are non-pregnant women, and they are comparing this to BPG. So I look forward to seeing these results. Cefixime is a medication we are very comfortable with in pregnancy, so we'll see where that data falls out. Azithromycin has been one of the recommendations. However, it's not officially recommended for syphilis treatment currently due to the emergence of azithro resistance mutations. Treatment failures certainly have been reported, so we are not recommending the use of that in pregnancy. A couple of the different guidance mentions, as I said, tetracycline or doxycycline. However, these are contraindicated in pregnancy, so we do avoid them if at all possible. And erythromycin, also in a number of the different regimens, including the World Health Organization regimen. Just be aware that it does not cross the placental barrier completely, so the fetus is not adequately treated. So very importantly, if you're going to use one of these alternative regimens, make sure the infant is treated with a penicillin regimen if at all possible. And if penicillin is not available for the infant also, the World Health Organization and the CDC does have some guidance on what you would use if penicillin is not available. I did want to just put in this plug for penicillin desensitization. George Wendell put this out back in 1985, and we're still using this regimen or similar regimens with a mixture of oral, IM, IV penicillin for desensitization. Desensitization is perfectly acceptable in pregnancy. So if your issue is not a penicillin shortage, but a penicillin allergy, please don't forget that penicillin desensitization is a very good option instead of moving to one of the alternatives. So with that, I actually ended up right at 15 minutes. I want to thank you very much. And I did put my email address here because since we're doing this on a virtual basis and I'm not here directly to be answering questions, I wanted my address on there so you guys can email me if you have any questions. And with that, I will finish. Thank you very much for your attention.
Thank you, Dr. Sheffield, for presenting today.
We would like to take a minute to thank all of our presenters for their presentations today, and a special thank you to my co-moderator, Dr. Laura Bachman. And another special thank you to you for joining us today. As a reminder, please join us September 18th from 3:50 to 4:10 p.m. Eastern Standard Time for a live Q&A with our presenters. Once again, thank you and have a nice day.